Hi, and welcome to Psychiatric and Mental Health Nursing. My name is Ann Nolte. I'm your instructor. We have 40 minutes to go through this slide. This is the fourth time I have done this presentation trying to get it to you. So now I'm trying another medium. The background behind me is Maui. Wish I was there, but we can be there in our minds. So the first thing that I want to share with you is that our brain is truly amazing. Our brain actually only weighs about 3 pounds. It's 60% fat, has over 86 billion neurons. We have 60 to 80,000 thoughts per day. That means it's about 2,100 to 3,300 thoughts per hour. And most of those thoughts are totally subconscious. We don't even know that we're having them. Info travels around our brain at about 270 miles an hour. That's pretty quick, especially if you think about the short distance that it does have to travel. And to do all that thinking and everything that our brain does, it takes a little over 500 kilocalories a day. The brain itself does not have any pain receptors. However, there are pain receptors, like the dura layer is able to sense pain, and that's a lot of times why we get headaches. We really started to learn a lot with in 335 BC, Aristotle thought that the brain was a radiator that kept the heart from overheating. And then in 1848, we learned a lot from Phineas Gage. He was a railroad worker, and he was working with explosives and a long rod iron. Well, the explosive went off early, and the rod iron went right through his left cheek, up through his head and his left frontal lobe. And right there, we learned a lot about personality changes and functioning. Apparently, he had a lot of anger and kind of mood swings after that. So they learned things. There is a book about Phineas Gage. His doctor actually wrote it. In 1900, that's when microscopes really started coming on the scenes, and they showed us a lot of things. 1906, Kajal and Golgi, you probably recognize that, were awarded the Nobel Prize for identifying neurons, and they decided they were the building blocks. And not only were they the building blocks, but there were many different types. 1932, Sherrington and Adrian won a Nobel Prize for identifying the synapses, so that was how our neurons communicated. There's a space between the neurons, the synaptic cleft. And then in 1963, Hodgkin, another name that you should recognize, Huxley and Asseles won the Nobel Prize for showing that neurons actually communicate through electrical and chemical means. So we do have neurotransmitters. We started to identify the neurotransmitters, and I would say the first time that I ever heard the neurotransmitters, I took my first class probably in 1994, and we had identified about 5 neurotransmitters. Now we have subtypes of subtypes, and it's just amazing how much information we actually have. Some of the neurotransmitters are acetylcholine, that is implicated in Alzheimer's disease and Parkinson's disease. We have the glutamate, which is excitatory in nature, and we believe that it is involved in the memory. GABA neurotransmitters, they're inhibitory in nature, and they're often targeted in treatment of anxiety disorders and insomnia. GABA also, that's what alcohol attaches to. It attaches to the GABA receptors, and that's why when we drink, we feel kind of nice and calm at first. Now, as if we abruptly stop drinking, then the alcohol is ripped off. And that's why a lot of people can go into DTs, because instead of being inhibitory, it becomes excitatory. We'll get into that later on. Glycine, that's an inhibitory and influences brain development. We think. Motor control, pain perception. You have your dopamine. That's involved with learning, emotion, motor control, executive functions, and we think it's very much related to schizophrenia and some psychosis. Norepinephrine it's central nervous system, it's in there, and then in the sympathetic nerves. Also controls anxiety, stress, sleep, attention, and focus. And you will know that from the SNRIs, those medications. Serotonin. Well, we have serotonin in our body, and our GI. Our GI are actually our intestines makes it. It controls GI functions like appetite and digestion, and also things to do with our cardiac. Our brain also makes serotonin, and that affects our mood, ADHD, sleep-wake cycles. And the cool thing is, though, is that the serotonin that's produced in the body isn't able to cross that blood-brain barrier. So I don't know, I think that's kind of interesting. There are a lot of theories of mental health, and we're going to cover just a few of them. So the first theory that most nurses know for sure is Maslow. He had the hierarchy of needs. It was Abraham Maslow, born in 1908, and he passed away in 1970. He believed that there were different levels of development, I suppose you could say. And the beginning are the basic needs, the deficiency needs. So the first one at the bottom is the physiological needs, and that's like food, water, warmth, rest. We have to meet these basic needs. Once we meet them, again, the security and safety is also very important. Now you can see like food, water, warmth, and rest we need or we would die. Security and safety, they're very nice to have. However, they're not as important as food, water. Okay, so then we go into the psychological needs. That's belongingness and love. Once we have these two, the safety and the physiological, we are able to move up and get relationships. Then we start to build some esteem, and we get hopefully some prestige and feelings of accomplishment. Once we're able to accomplish all these things, then we go into a phase called self-actualization. And that's when we're able to achieve our own full potential, and we become more creative because we're not worrying about all these other things down here. Maslow believed that for these basic needs and psychological needs, when they are unmet, it motivates people. The B needs, are growth needs. All right, so we must have a desire to grow as a person. That's what Maslow believed, that we will have this inner desire to get to self-actualization. And different life events can cause us to jump around, and we can see that right now with the COVID-19. A lot of people who may have been in the self-actualization phase are now worried about food, water, security, safety, housing, okay? The next person that we're going to talk about is B.F. Skinner. He's operant conditioning, and he believed that we need to look at observable behavior instead of inner thoughts, that it's more why we do what we do, and we do things that give us a positive reward, and we try to avoid things that give us a negative reward. He based his theory on the law of effect by Edward Thorndike, and he just believed the consequences influence behavior. I'm not sure how true that is, because I know quite a few people who do things and they get negative consequences, but they still continue to do. The next person is John B. Watson. He's a behavioral theorist, and he did the study with little Albert. The little boy's name was actually Douglas Merritt. He died at 6 years old from hydrocephalus. And what Watson did is showed Doug a white rat. Every time he saw the white rat, he would sound this very loud clang, and little Doug associated the rat with a very loud, disturbing noise that scared him. So then he wouldn't even have to hear the noise. As soon as he saw the rat, he would cry. Very neat study. Watson published The Psychology as the Behaviorists Use It in 1913, and he just believed that we can predict and control behavior. There's a lot of therapies that are involved with mental health. Some of these theories are the milieu theory, the cognitive behavior theory, behavioral therapy, therapy, interpersonal psychotherapy, psychoanalytic psychotherapy, that's a mouthful, and then modeling. We're going to cover a few of these, just two, I think. So milieu therapy says that if you change the environment, you change the reaction. It is a long-term therapy. It's very structured. It encourages a supportive environment. The group is able to solve the problems. And it's based on the theory that people can use their own inner strengths to change undesirable behavior. I believe that social interactions also play a part. An example of this would be like the Oxford homes, where a bunch of people who are trying to recover from alcohol or drug abuse live together. They have very strict rules. They have to pay rent, they have to have a job, they can't use, they have to be part of the house, they have to make decisions as a house. It's very structured. And they encourage each other and they teach each other life skills and how to live a life without using. So that's the milieu therapy, and that's mostly about the environment. Cognitive behavior therapy is very, very, very popular. And it's a psychotherapy, which means that it is a talk therapy. It helps the person become aware of negative and disturbing or inaccurate thinking. It believes that if you change or redirect the thoughts that are negative, then you will be able to change the way you're thinking and change the way you're behaving. It's very structured and it's short term in nature. So what's considered short term? Well, that depends on the person. It can be 3 months, 6 months. It can be either individual or group, and it is very, very popular. Hildegard Peplow is a very famous nursing theorist. She is considered the mother of psychiatric nursing. She lived from 1909 to 1999, so she was 90 years old when she passed. She published the theory of interpersonal relations. And what she did, what was really neat, is that she pulled information from other fields, other professional fields, and brought them into the field of nursing. So it helped bring evidence-based practice into the nursing field and help to make nursing a profession instead of just a practice. So she defined the care, the relationship between the nurse and the patient as patient-centered, but it was a nurse-patient partnership, and that there were phases of this relationship. She believed that the nurse does not take a passive role and the patient does not take a passive role. It's a relationship, it's a partnership. It involved 4 components: the person, that's the patient, the environment, it has to have a supporting environment, the whole relationship. Health, it's health obviously centered, and nurses have to be supportive as well and very active in their role. Peplow said there are 4 sequential phases. So in other words, these phases have to go in order. You start with the orientation phase, that's when identification phase, where you get to know the problem, exploitation, and then resolution. Resolution is when we resolve the problem. 7 nursing rules. You'll find that nurses we have a lot of roles. We wear a lot of different hats. We have the stranger role, the resource role, the counseling role, surrogate role, active leadership, and technical expert role. Assumptions of Peplow's theory: nurse and patient can and should interact. Both the patient and the nurse mature as the relationship goes on. And we mature as a result of the relationship. My patients have literally made me a better person. Communication and interviewing skills are functional nursing tools. So we have to be able to communicate, we have to be able to interview people. Nurses have to clearly understand themselves so that the client or the patient can grow and all choices can be examined, because we cannot give away something we don't have. So we have to be able to understand ourselves. Okay, understanding humans. According to the World Health Organization, 4 out of 10 people in the United States are disabled by mental illness, and that means disabled. What is normal? Well, that's defined by culture, time, politics, media, beliefs, society, religion, situation, social class, age, and I think personality. I think some personalities are more accepting of change than others. So it does involve many factors. So you can't just say that's not normal. That's not normal to whom? But we try to figure out what is the difference between, quote, normal and what would be mental illness. In the beginning, we looked at the people who were not able to cope. They were not able to function because of their mental illness. And so the government, well, I think it was the government, decided to make this statistical manual for the use of institutions for the insane. And it was 37 pages. The information was gained from the state mental institutions. And they basically tried to classify what was insanity. They looked and they actually categorized kind of some of the characteristics of people who were in insane asylums. And remember, they were state run. Eventually, we replaced that with the DSM-1 in 1952. So the DSM, that's the Diagnostic and Statistical Manual of Mental Conditions, DSM, it went through lots of revisions. It seems like every so many years it goes through a revision. Our last one was in 2013. It is now 947 pages. And it tried to reclassify some of the disorders. And then it did away with that AXIS system, thank goodness. The AXIS system, it's just good for you to know what it is. You don't really have to learn the axes. We did, but you don't. It was used for 33 years. And basically, each axis is a different, it holds a little bit of different information for the whole picture. So Axis 1 was the signs and symptoms of major clinical disorder. Axis 2 looked at the past, so the history of the developmental disorder, antisocial, etc. Axis 3 was your general medical conditions that could contribute to the disease. The Axis 4 was any psychosocial or environmental issues that could affect treatment. So they looked at economic, educational, occupational. Axis 5 was the global assessment of functioning. And so they would rate how functional this person is as a result of the disorder. So 1 to 100. The DSM-5, like I said, did away with that whole AXIS system. Although you might see it in some of our older psychiatrists, I want you to know what it is if you see it. The DSM-5 is like the Bible of psychiatry. And these are the chapter headings. So I actually went through my DSM-5 and wrote down the main chapters. And you can look at these. Neurobiological schizophrenia spectrum. Now see, schizophrenia is now on a spectrum. And other psychotic disorders, bipolar and related disorders, depressive, anxiety, OCD and related disorders, trauma and stressor related, and dissociative disorders. The DSM-5 tells us the diagnostic criteria. So it tells you, how do you know that general anxiety disorder, how do you know if a person's suffering from that? Well, this is what they're going to show. It tells you the diagnostic features, the prevalence. So how prevalent is this in our society? The development and the course of the disorder. And then it goes on, the risk and prognostic factors, gender-related diagnostic issues, suicide risk, functional consequences. So this basically is all the different information we have been able to collect on the disorder. The differential diagnosis is what medical conditions can this be caused by, or what could be contributing to the disorder itself. DSM-5 has diagnostic. It lets us diagnose the situation, I guess. The expected assessment, so what are you going to find? And then all this information that we find is able to help us provide the best planned care for the patient. Because not only we can know what questions we want to kind of ask the patient based on the information that we have. It can help guide us. The other book that's not as important as the DSM is the International Statistical Classification of Diseases and Related Healthcare Conditions, or in short, the ICD-10. This is prepared by the World Health Organization, and basically what it does is takes every disorder and gives it a number. Most of the time, insurance people use these numbers, and you'll see these on your bills and different things. So it has all diseases, abnormal findings, complaints, signs and symptoms. So it tries to give everything that a human being can possibly have a number. For example, moderate cocaine use disorder is F14.24. The ICD-10, you just should know what it is, not all these counts. Nursing diagnoses are created by NANDA. NANDA has said there's 4 basic categories: actual, risk, health promotion, and syndrome. The ones that you'll see the most are actual, which means the patient's actually having this sign or symptom or disorder. Risk, which means they're at risk for. Health promotion, so we're going to educate. That might be a health promotional activity. Educate patient on disorder. And then sometimes you'll see syndrome, but mostly these top 3 you'll see the most. This is part of the nursing process and involves clinical judgment, so that, it has to be relevant. How nurses care and monitor patients. And this tells us what we're going to do. There's lots of mental health organizations and associations. Some of the very common ones are the WHO, which we've been hearing a lot about. National Alliance on Mental Illness, that's NAMI, and I'm going to actually help try to get a NAMI representative to come and speak with us during one of our class times. Then you have SAMHSA, SAMHSA, the Substance Abuse and Mental Health Services Association, American Hospital Association, National Institution of Mental Health. So you have all these different ones. My favorite is the American Psychiatric Nurses Association. That is for nurses, the APNA. I get their magazines, and I am a member of that association. Mental health is on a continuum. So we go from non-functional to better than baseline. Non-functional is that person has the mental health issue is affecting them so bad that they're not able to function normally. Symptomatic means, well, I have symptoms, but I can kind of function, but not as good as I should be. Baseline means I'm okay. I'm functioning at my level of okayness. Better than baseline is where positive psychology comes into play. And that's where you hear the emotional intelligence, resilient, mindfulness, purposeful living. All these kind of characteristics are part of the positive psychology. And that's saying what they did is they studied all the people that were happy and positive and content, and they were reaching their dreams, and they studied them and they said, what characteristics do they have? And that's where positive psychology is now coming from. Most of the theories that we talk about are just trying to get people up to this baseline. But now we're starting to get people how to even have the better life or live the best life now. So mental health, all these things, it's a personal journey. Some people are happy just living at baseline, and some people want to keep learning how to do better. It varies by different life factors and the coping skills of the person. So we all have our own virtual reality, and our virtual reality is the reality that we perceive. You change the perception of the reality, you can change the way a person thinks and the way a person acts. It also depends if you're a pessimist or an optimist, and then how resilient you are. So some people who are really freaked out right now with this COVID-19, they may be losing their resiliency, and we're going to see a lot of mental health issues as a result of this whole situation. The diagnosis and the treatment is based on evidence. So it's not like we're just trying something out. It has to be backed by some kind of evidence that it's going to work. But remember, we are dealing with people's lives. Psychiatric illnesses in Western society, we have found that it is neurobiological in nature. So this is a real illness. Treatment for psychiatric neurobiological illness in the Western area is psychopharmacy and therapy. So we use medication and we use therapy. We have standardized assessment scales for diagnosis and history observation, assessment, and evaluation. And some of these scales we're going to go through in this class so that you can kind of see. So when we talk about normal for mental health, we say that it's different for everybody. Everybody functions at a different level, and we want the person to function at the highest level that they can. We want people to be resilient to most of life changes. We want them to have healthy coping skills and ability to care for themselves. We also want them to participate in healthy relationships and be comfortable with themselves. This is very important for nurses. And normal depends on many factors. So we want to know the stressors of life. So that's our external pressures. We also have to know the internal pressures. That's the personal standards that a person has. People should know that how to set boundaries. That's part of being healthy. And then ability to communicate with others. So we have a lot, this is things that we can always improve on. Heredity and biology can't really change that. Neurotransmitter dysfunction and brain structure can't change that. They did studies on schizophrenia and found that the people that suffer from schizophrenia actually have different brain structures. It also depends on culture, age, location, whether urban and rural. I think it also depends on the information that we were taught as a child. But we can always learn new things, right? So we just have to know that there are new things to learn and be always open to them. Now, abnormal is different in various cultures. For instance, I heard a story about an African farmer. He was very depressed, and his village was concerned with him. And he just didn't want to farm anymore. He would just sit and cry. So the village came up to him and they talked to him. And they realized that he was just tired of farming. So they said, well, we do need a goat herder, so why don't we try him on that? So they brought him some goats, and he was thrilled. His depression went away. He loved caring for the goats, and that's that story. So that's how they dealt with it. Eastern medicine deals with it in their own way. Western medicine, we deal with it with medication and talk and therapy, different kinds of therapy. So you can see that there's a lot of variations, and now we've come up with the recovery model. So the recovery model says that this is based off Alcoholics Anonymous, the 12 steps of AA. It says that first we have to recognize there's a problem and commit to change. So you can't change anything until you know there's a problem and we're ready to change. So then you have to tolerate being uncomfortable, because change is not easy. It takes change. I mean, change takes being uncomfortable. And change is sometimes uncomfortable for people. And then you want to replace old behaviors with new. That's change. Then once you've learned to do this, you go ongoing self-care, and then you learn some more coping mechanisms, and they improve self-esteem. So this whole thing, this is a very simplified model of it, but it's based on the 12-step program of AA. It is a personal journey of healing. The goal is to empower people and help them find meaning and satisfaction with their life. You have to realize your own personal potential, function at your personal optimal level. You want social inclusion, hope for the future. We teach people their needed coping skills, and you have to believe that you can recover, and then you learn to believe in yourself. I know this was a really, really fast way to roll through this. It's just with Zoom, I have 40 minutes to do this whole thing, and the whole thing actually takes about an hour. So I hope that you got something from this. I'm sorry it was so fast. I'm trying to get this WebEx to work and fix the recording. And I hope you have a great day. Please email me or text me with any questions. You can also try calling, but that doesn't always work really good. All right, have a great day, and namaste.